Good morning. We are sorry for the delay. Let me call first presenting author, Dr. Harshita Hiran. Is she there? Please. Sheet.
Good morning, everyone.
Start, please.
Hydroimplantation is a technique involving implantation of the IOL under irrigating solution without the use of viscoelastic device. Retained viscoelastic after cataract surgery can cause post-op inflammation, raised intraocular pressure, toxic anterior segment syndrome, which can lead to post-op discomfort and pain to the patient. Few surgeons use irrigation and aspiration probe, which cannot be done in coaxial irrigation and aspiration. Few use hypodermic needles, which can be injurious to the iris tissue. No specific device is available for the same. Thus, we devised a novel hydroimplantation cannula, which is a 20 gauge stainless steel cannula with a 120-degree bend containing one slit opening inferiorly and one on the side. The side opening allows to keep the anterior chamber formed, and the inferior opening helps to inflate the bag throughout the procedure. The cannula is attached to the irrigating fluid, following which it is inserted through the regular side port. The IOL is injected from the main port. After the unfolding of the IOL, it can be dialed into position. The below videos shows a side view of the procedure being performed. In India, maximum number of cataract surgeries are done by manual small incision cataract surgery technique. The hydroimplantation cannula can also be used in SICS surgery. After inserting the cannula from the side port, the rigid IOL can be inserted from the tunnel. The AC remains formed and the bag remains inflated throughout the procedure. After inserting the intraocular lens, it can easily be dialed into position in the bag. The advantage includes that it saves time and reduces post-operative uveitis and toxic anterior segment syndrome. Cannula can also be fixed to the limbus with a bolster, and thus using a screw type injector we can use to implant the IOL with both the hands. Hydroimplantation cannula is also useful in insertion of the toric intraocular lenses. After inserting the cannula from the side port and injecting the toric IOL, it can be dialed into position according to the surgical marking. Its advantage includes that there is less chance of post-operative rotation of the IOL as no viscoelastic device has been used. AC maintainer has a specific use to maintain the anterior chamber, whereas a hydroimplantation cannula can also be used as a second instrument while doing the surgery. In hydroimplantation, the IOL unfolds slowly as the glass transition temperature is low, whereas under viscoelastic, the unfolding is faster because of high glass transition temperature. Another use of the cannula is that it can be used as a second instrument. After inserting the cannula and injecting the IOL, the hydroimplantation cannula can be used to manipulate the IOL and help in opening of the haptics. It also helps avoid flipping of the intraocular lens. Thus, we did a study to analyze the safety and efficacy of the cannula For hydroimplantation of IOL, we divided 20 eyes into group 1 for phacoemulsification and 20 eyes in group 2 who underwent small incision cataract surgery. Surgeries were done by 2 surgeons, 10 each in each group, who had never done hydroimplantation before, and following the surgery they were asked to fill a questionnaire about learning and ease of use. All eyes were examined 3 hours after surgery under slit lamp. The results showed that the learning curve was equal in both the groups. IOL implantation was easy in both groups. All eyes had clear cornea post-operatively except 2 that had mild striate keratopathy in group 2. None had significant post-op AC reaction. None of the eyes had any congestion. They were quiet and no pain was complained by any patient. Thus, we conclude that the cannula helps in smooth implantation of the IOL, can be used in phaco and SICS surgery, first of its kind, avoids post-operative viscoelastic related complications, reduces the surgical time, and allows the use of both the hands for implantation of the IOL.
Yeah, very nice presentation, Dr. Harshita. Two questions. Where are the ports situated? You said one is round port, which is faces posteriorly, and other is slit-like opening, which is superiorly.
No, sir. There is one opening inferiorly and one on the side. So the idea is that the inferior opening will help to continuously inflate the bag, and the opening on the side will help to maintain the anterior chamber.
And do you hold it with one hand or you just keep it? Like I noticed in your SICS cases, it was just kept like that.
So we can do both, sir. Like usually we do hold it, but we can also fix it with a bolster at the limbus, and if we want to implant with both the hands, that can also be done.
But my fear is that in SICS cases, if you fix it with a bolster and implant the lens, because of fluctuation, it might go and hit against the endothelium.
So we have not seen face
because
difficulty.
the opening is big in SICS, fluctuations will be more, which may not be there in visco. But with hydroimplantation, this looks good in phaco, but in SICS,
so
I have my
SICS,
doubts.
personally, I felt that while holding the, if you are holding the
Yes, you have to
implantation-
hold it. You cannot just leave it like that.
Yes, sir. That
Okay.
way we have good anterior chamber.
What is the diameter of this?
So point
Diameter.
0.3.
What is the gauge of this?
20 gauge cannula.
And what is the cost?
Sorry, sir?
Cost.
Sir, I am not aware of the cost. I am so
All
sorry.
right.
Yes, sir.
Thank you.
Thank you, sir.
So next speaker is Dr. Shweta Walia. Cutting edge approach, sutureless, glueless SFIOL to manage aphakia.
So good morning everyone. Cutting edge approach, sutureless, glueless SFIL to manage aphakia. We all encounter cases of aphakia every day, and we must be well versed with the technique to manage it so that we give a good visual outcome to the patient. There are multiple techniques to manage it. ACIOL has multiple complications as is not preferred technique. Iris fixated IOLs, they can be either anterior or retrofixated. SFIL is another technique which can be either sutured or sutureless. The sutured SFIL involves manipulation of fine 9-0 or 10-0 sutures, and there are high chances of suture breakage, not exposure, not slippage, IOL dislocation, and retinal detachment. And this led to the evolution of sutureless technique of SFIL, which involves use of a microaxis forceps to exteriorize the haptics and glue to fixate them to the sclera. However, both of these make the surgery expensive. Yamane technique is another technique of sutureless, glueless SFIL, which gives a stable IOL fixation and avoids complication. It has haptic flange creation. Though not very much convinced with the Yamane technique, we realized that the inside diameter of a 26 gauge needle is 0.26 mm, which is large enough to insert the haptic of a 3-piece IOL, and hence the need for a microaxis forceps is not there. So you can see in this video that the haptic of a 3-piece IOL can be easily trailed into a 26 gauge needle, and this led to our technique of SOL. We pre-mark the cornea and our entry points, center of the pupil, and at 4 o'clock and 10 o'clock position, a bent 26 gauge needle is traversed into the eye, brought out of the scleral tunnel, and haptic of the 3-piece IOL is trailed into the bent 26 gauge needle, and as you withdraw the needle, the haptic is exteriorized. Now this haptic is tucked into sclera using another 26 gauge needle. It is advanced intrasclerally to come out just at the exit of the haptic, and we traverse the haptic into needle, and as you withdraw the needle, haptic goes intrasclerally. The same is done on the other side, and you can see that a well stable IOL is achieved. Now let's see in this video, a bent 26 gauge needle is traversed into the eye and then brought out through the scleral tunnel. The haptic of the 3-piece IOL is traversed into the bore of the needle, and as you withdraw the needle, the haptic is exteriorized. There is no need for a microrhexis forceps. Now another bent gauge needle is taken, traversed intrasclerally to come out just at the exit of haptic, and the haptic is then traversed into the 26 gauge needle, and as you withdraw the needle, the haptic goes intrasclerally. Similarly, on the other side, another bent 26 gauge needle is taken, brought out of the scleral tunnel. The haptic is railroad into the bore of the needle, and as you withdraw the needle, the haptic is exteriorized. Now you take another 26 gauge needle, traverse it intrasclerally, and bring it out at the just at the exit of haptic. Then again railroad the haptic into the bore of the needle. Now as you withdraw the needle, the haptic goes intrasclerally. So everything is being done extraocularly, and you complete the surgery by doing vitrectomy and forming anterior chamber. And since everything is being done extraocularly, there is minimal inflammation in the eye on day 1 post-op. A well-centered IOL can be seen with no inflammation. Anterior segment OCT picture to show the stabilization of the IOL. We also have tried doing this case making scleral flaps, but we found that there is no advantage of making scleral flaps, as in none of the case there was haptic exposure. On the other hand, making flaps complicates your surgery with the need of an assistant to help you. Now when we go for a cost benefit analysis of our technique, we find that the cost of the surgery is minimal. It is only of that of the IOL is the cost. We showcased this technique in 2017 and it was published in AIOS Times in 2021. We published our results of 50 patients in AIOS in 2022. These are few of our post-op cases. Well-centered IOL. So you can see that there are no suture related complications. Learning curve is not much. As we don't need suture or special forceps or glue, the cost of the surgery is cut down. 26 gauge needle, 30 gauge needle are very fine, and thus the entry ports are very fine and small, and so there is no leakage and early post-op recovery is seen. Haptics fit snugly in 30 gauge needle or 26 gauge needle, and thus no chance of longitudinal displacement even if we don't use glue. Thank you. Thank you so much.
Very nice technique, Dr. Shweta. What is the length of this thing, passage of 26 gauge needle intrasclerally where you are placing the haptic? Because
Sir,
does the tip come out or the tip stays in the tunnel?
It stays in the tunnel.
So what is the length?
So we actually, when we can, the haptic is placed on the sclera, so you can see till what length it is coming before we traverse into the sclera. And then when we see that it is from here, from that point only we start and come out at the exit of the haptic. So many times the eyeball is small, the corneal diameter is small. So the length of the haptic that comes out is different for every case. We can't predetermine it that we'll make a 4 millimeter or a 5 millimeter tunnel. So what we do is, when one haptic has been brought out, at what point it comes out, we start from that and come at the haptic end. If I can...
And do you mark the place, the distance from the limbus where you insert the needle?
Yes, yes, yes. We
How much is
pre-mark.
that?
So 1.5 millimeter from the
1.5.
limbus.
So, and how do you ensure there is no tilt of the
So
lens?
we are doing, earlier in 2017 we were not having the anterior segment OCT, but now in every post-operative case we are seeing and doing anterior segment OCT, and the IOLs are very well stabilized. If the markings are done properly, there is no tilt in the IOL. And we have a long follow-up of our patients, and lucky to say that none of the patient had any retinal detachment, as we used to see in sutured SFIL cases. We had done a comparative study also from sutureless SFIL to sutured SFIL, and definitely the better outcome is there.
Right.
Well, how much period is the long-term follow-up, ma'am?
So from 2017 to 2025, in amongst one of my earliest patient was my staff patient who is in regular touch with me, and he is doing wonderfully good.
And you said economical, thing.
Yes.
So in comparison to what you have compared?
The sutured SFIL, if you see that the SFIL, it comes around 1250 rupees, and the suture cost is attached to it, 350, 700. And when you compare it with a glued IOL, in that the glue cost is also there, the cost of the MST forceps is also there. Many times the tips of the MST forceps is broken and we don't have anything. McPherson forceps is readily available in our OT and nothing happens to it. So with the simple things we can do wonders.
Right. Thank you.
Thank you.
Can I have the scoring sheet, please, audiovisual people? Scoring sheet here.
Next is Dr. Joseph. Next is Dr. Josephine Christie, Dr. Naveen Radhakrishnan.
Good morning, everyone. This doesn't have to be so difficult. Come.
Procedure 1. Items required are Pro Circle, or a stencil to hold items in place. Jelly candy to stand in for cornea. Crushed pepper to mimic iron or stone foreign body. Toothpicks for simulating thorn. And bristles of a toothbrush for caterpillar hair. Corneal foreign body removal simulation. Take the jelly. Use the forceps to place the crushed pepper, toothpick pieces, and bristles in the jelly. Next, secure the stencil to the slit lamp by tying it with a piece of thread. And then start removing the foreign bodies. Procedure 2. The following are the items required: Pro Circle, a bouncy ball, and tissue paper. Corneal scraping simulation. Wrap the bouncy ball in tissue paper, pop it into the stencil. Sketch out the ulcer with some yellow and green. Vet the tissue. Then scrape the colored area. Procedure 3. The required items are Pro Circle, bouncy ball, and marker. Glue simulation. Place the bouncy ball in the stencil. Mark it with a marker. Add a drop of water. And then glue it up by targeting the marked spot. Procedure 4. The required items are Pro Circle, sutured styrofoam, tape, suture removal simulation. Place the double-sided tape onto the stencil. Stick the sutured styrofoam, which was once used for suture practice, onto the stencil. And then, it's simply a matter of removing those sutures.
It has improved my hand-eye coordination.
Hand-eye coordination.
Hand-eye coordination.
My hand-eye coordination.
I feel more confident about doing the procedures in the OPD now.
It doesn't have to be this difficult. Come.
I think having simulators, not only for these OPD procedures, but also for surgery, it's a good concept which goes a long way in improving the standard of postgraduate teaching. Thank you.
Nice thing for PGs.
I like the way you started with the perspiration and then doing that. That was an interesting thing.
Thank you, ma'am.
Thank you, doctor. So next is Dr. Harini R. Dendrites versus pseudodendrites, deciphering the clinical conundrum.
Good morning, everyone.
On a beautiful evening, after a heavy cornea clinic, our resident Pooh sat under a peach tree, reflecting on the day's events in the clinic. But something was bothering him. What was it? He had diagnosed a patient with dendrite and treated him with antivirals, but on follow-up, Master Shifu found that it had worsened and turned out to be a full-blown fungal ulcer. Pooh was very frustrated and confused, so Master Shifu asked him to meet after the clinic the next day. And the teaching began. Infectious keratitis stands as the 5th leading cause of blindness worldwide, affecting over 2 million people each year. Infectious keratitis can be microbial keratitis, caused by bacteria, fungi, parasites, or viral keratitis. A significant proportion of these cases arise in poor resource settings, like South Asian countries, highlighting the crucial need for early diagnosis and proper treatment. Diagnosing dendrites and pseudodendrites clinically is often challenging. Therefore, differentiating them requires profound knowledge and careful observation. Dendrites. The term dendrite comes from the Greek word dendron, meaning tree, which describes their branching pattern. Dendrites are linear epithelial defects with an arborizing pattern. They have raised epithelial borders with central ulceration, and distinctive terminal bulbs at the ends of the branches. They manifest as microdendrites that coalesce to form dendritic ulcers and are classically associated with herpes simplex virus keratitis. Dendrites can deceive our eyes like certain creatures in nature that are hard to spot. They might not be visible under diffuse illumination, but their presence can be appreciated under focal illumination using a slit. Their visibility is enhanced with stains like fluorescin, rose bengal, or lissamine green, which helps to delineate them from the surroundings. Fluorescein dye diffuses through the disrupted intercellular junctions and epithelial cell loss and adheres to the basement membrane, therefore highlighting the areas of epithelial breakdown by staining the bed of the ulcer. Rose bengal or lissamine green dye have a high affinity to stain the dead and devitalized epithelial cells, thus staining the raised epithelial borders of the lesion that harbor the devitalized epithelial cells. Pseudodendrites. These are lesions that mimic dendrites but lack the characteristic dendritic pattern. The common differentials for pseudodendrites are fungal keratitis, herpes zoster ophthalmicus, and healing epithelial defect. Fungal keratitis is the most commonly misdiagnosed pseudodendrite. Let's do a Furious 5S test to differentiate them from dendrites. Symptoms. Fungal keratitis presents with severe redness, pain, irritation, and history of vegetative matter injury, while dendrites will have mild irritation only. Signs. Fungal keratitis will have congestion and edema, whereas dendrites will have a white eye. Fungal pseudodendrites lack the characteristic arborizing pattern and terminal bulbs of true dendrites. Stroma. The level of lesion is stromal in fungal and epithelial in dendrites. Stain. Fungal pseudodendrites may take up stain, but it will not be of a typical dendritic pattern. Sensation. Sensations will be lost in dendritic ulcers, whereas usually intact in fungal. Herpes zoster ophthalmicus. They are superficial and appear as branching patterns with blunt ends, giving a painted-on appearance. These lesions can develop weeks to months after the resolution of the skin lesions. They are more superficial than HSV dendrites and take up stains, but lack central ulceration, raised borders, and terminal bulbs. Healing epithelial defect. The migrating epithelial cells from the edges of the epithelial defect tend to form sheets of advancing epithelium moving toward the center. As these sheets come into contact with one another, an epithelial healing line is formed. This has the appearance of one or more Ys joined at the base, creating an appearance reminiscent of a dendrite. These healing lines take up stains, but lack the distinctive arborizing pattern and terminal bulbs of true dendrites. Special situations include recurrent dendrite and healing dendrite. Recurrent dendrite will have a stromal scar associated with a dendritic lesion. Fluorescein staining will help in enhancing the epithelial defect. In healing dendrites, there will be remnants of dendrite, but the stain will lack the characteristic dendritic pattern. Diseases may deceive us with their varied presentation. Differentiating dendrites and pseudodendrites can pose significant diagnostic challenges. However, through meticulous examination, we can distinguish them apart, thereby providing effective treatment, enhancing patient care. And yes, finally, our resident poo attained inner peace.
So I just have one question. What gave you the idea of doing this? Dendritic, we always have in undergraduates, we have this question and we keep having it. So what was your initiative?
Like as residents, we had a great confusion in the OPD on diagnosing dendrites or pseudodendrites. We get often confused. So we asked our mentor, our senior MOs. So they used to tell these differentials. So we found it very useful. So we thought, I thought that it will be useful for everyone
would say to take it further because it's very often recurrent in patients. Have a simpler one and then show it to the patient so that they can come for timely follow-up. Follow it up with another video.
Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
Thank you. So next is Dr. K.M. Thomas.
Can the other person be there on the podium, the next person? Dr. Zia Sultan, and presenting author is Dr. Aditi Rao.
Dr. Aditi Rao, yeah.
Is she there? If she's there, she can go on the podium there. No, she's not there. Okay, please carry on.
Good morning, all. Algebrush with the diamond burr have been commonly used in ophthalmological surgeries. Here we present multiple unique corneal conditions that can be treated with this versatile instrument. One of the most common indications for using a diamond burr is in the treatment of recurrent corneal erosions. The loose epithelium is first peeled off along with a rim of surrounding epithelium. The burr is then used to polish the surface. The central area underlying the erosion is polished first, followed by polishing of the periphery. Antibiotic drops are instilled and a bandage contact lens is put. The next use is in the case of a shield ulcer. The burr can be safely used in lesions involving the visual axis as it does not cause any permanent stromal scarring. The diamond burr can also be used to aid the process of EDTA chelation for band-shaped keratopathy. The ocular surface is polished with the diamond burr while EDTA is simultaneously instilled drop by drop. As seen from the surgical recording timings, the entire procedure of EDTA chelation for band-shaped keratopathy can be completed in just 5 to 6 minutes with the help of a diamond burr, in contrast to the conventional process which takes around 15 to 20 minutes. The next indication is a corneal scar post-pterygium excision surgery causing an irregular corneal surface. The patient presented to us 3 years following a double pterygium excision with a nasal and temporal corneal scar. We can see the scar tissue being removed with the forceps, followed by polishing of the surface with a diamond burr both nasally as well as temporally. Next is a case of epithelial hypertrophy with underlying scarring post deep anterior lamellar keratoplasty. The burr is used to gently scrape the hypertrophic epithelium and to polish the underlying surface. We can notice the real-time clearing of the hypertrophy intraoperatively. It is also important to note that scar have been cleared while at the same time maintaining the graft host junction integrity. The advantages of this technique being it has less steep learning curve and it is economical. It does not cause any permanent stromal scarring and hence can be used to treat visual axis lesions. It causes only low recurrence rate in case of recurrent corneal erosions. Retreatments are easy. There is no chance of any corneal perforations and it does not cause any significant refractive shift. In conclusion, diamond burr is a simple and humble tool which can be used by a comprehensive ophthalmologist for treating a wide variety of corneal conditions.
This diamond burr is it rotating? The tip
Yeah,
is
yes, sir.
rotating. What is the frequency of rotation? Can you regulate it?
No, sir. It's
It's a fixed
prefixed
rotation.
only.
No, we can regulate it
No,
with the knob down.
Yeah, the algebrush, I'm not sure, sir. There is an on and off switch which we are using.
It's only on and off switch, or you can regulate the speed also.
It rotates from behind.
We can control
It connects the battery and then the tip rotates.
And what is the cost of it?
The motor is around 11,000 now, sir, and the tip is around 2,000. It's a one-time investment and like no financial disclosure, but we can use it can be sterilized and used like that. There is no maintenance needed.
So it can be used after pterygium surgery also, because
Yes, sir.
that is
Primary
where you
pterygium
really
surgery
need to
also
regularize the
Yes,
bed.
sir. Yes, sir. It is very helpful in that to remove that small fibrillary things after removing the pterygium head.
You had put the EDTA along with it. How did you ensure that the EDTA would not spread? In one video, you had shown that the EDTA was being drop by drop instilled.
We wash off the EDTA. Now we are not, in the BSK cases, now we are not doing EDTA. We are directly using the diamond burr over it. It was done before, ma'am.
Okay.
How do you sterilize this burr tip? How do you
Pardon?
sterilize it?
It's autoclaved, sir. The tip is autoclaved, but in the machine is like after all the surgeries, the last surgery will be the ocular surface surgery. Then we use only sterilium to sterilize the machine, and it is kept separately.
And the tip is autoclaved.
Sir?
The tip is autoclaved.
Tip is autoclaved, ma'am.
But it's a diamond tip, no? Will it diamond tip autoclaved?
Is it a diamond tip? You said 2,000 rupees, right?
Yeah.
Is it
It's
a diamond?
burr tip.
It's a burr.
Burr tip.
It's a burr.
Simple burr.
Simple burr tip.
How will you otherwise use it?
It's a simple burr tip.
And what is your financial implication?
No financial implications.
She said that.
It helped me. That is why
Thank
I
you.
made the video.
Is Dr. Aditi Rao repeating? She's there? Okay. Next is Dr. Khare. Can we call
Mukesh Khare.
Mukesh Khare. Then there's Dr.
Smruti Savale.
Shruti is there?
Smruti Swale.
Is Dr. Smruti here? Yeah. And then that's it, no? You just have
yeah.
two left.
Dr. Khare, please.
Dr. Khare and then Dr. Shruti, please be ready.
No, Dr. Khare is there. No?
Khare is here. Shruti is there.
Good morning, everyone, dear chairpersons and fellow delegates. Lacrimal irrigation is the most commonly done test to assess the patency of lacrimal excretory pathway. But lacrimal irrigation cannot localize the site of obstruction accurately. A single finding may have several interpretations. For example, a clear regurg from opposite punctum may indicate blockage at common canaliculus or in the sac or in the NLD. At times, the traditional understanding of lacrimal syringing is just a supposition. This young girl with congenital lacrimal fistula FDDT revealed freely patent lacrimal pathway. No exude from the fistula could be seen. Lacrimal syringing indicated presence of saline in nasal cavity. Some amount of saline oozed back from lacrimal fistula, and perhaps some of the saline wriggled back to the conjunctival cul-de-sac. To confirm the regurgitation, repeat syringing was done with colored saline, and we found a good amount of fluid wriggled back. We don't have any mechanism to calculate how much fluid wriggled back. It is a common knowledge that lacrimal irrigation does create a hydrostatic pressure. We conducted a simple experiment. We threw camlin ink of different colors in air with the help of 1 mm, 2 mm and 5 mm syringes with same cannula and same person. And to our utter surprise, the throw traveled 8 to 9 feet of distance. We may conclude from this experiment that lacrimal syringing does create a very high pressure. That is why the throw traveled such a long distance. Because of poor reliability of lacrimal syringing, we started looking for other tests. FDDT is the number 2, but it cannot localize the site of obstruction. Lacrimal scintigraphy has its own limitation with very poor anatomical details. We were looking for an alternative without these limitations. That took me to my physiomaxillary radiologist regarding the cone beam computed tomography machine. CBCT is a dedicated CT scan for dentistry. We have been doing DCG with the help of CBCT since 2017. CBCT DCG is done by installation of dye in conjunctival cul-de-sac. I repeat, dye is instilled in conjunctival cul-de-sac. Patient remains seated upright, normally blinking, and imaging gets completed within 13 seconds, making it a very safe procedure, and at the same time, all the physiological requirements are met. CBCT DCG provides excellent anatomical details and localizes the site of obstruction accurately. CBCT DCG utilizes the physiological forces to propel the dye along the lacrimal tree. This staged video of CBCT DCG images showing the flow of dye from canaliculus to sac, NLD, and to inferior meatus. This middle-aged woman with patent syringing, FDDT revealed obstruction on right side. CBCT DCG revealed pooling of dye in lacrimal sac, indicating blockage at the junction of sac and NLD, while the left side revealed presence of dye in inferior meatus, indicating its patency. And then we injected the dye, and syringing pressure easily negotiated that blockage. Dye started flowing through the NLD, and just watch the pressure at which dye is squirting in inferior meatus. This gentleman with patent syringing, FDDT revealed obstruction on both sides. CBCT DCG revealed pooling of dye in mid-segment of the NLD, indicating blockage. And then we injected the dye, and the syringing pressure easily negotiated this blockage, which was a dacrylith, and dye went all the way into inferior meatus. This lady with patent syringing revealed obstructed lacrimal pathway on left side with the help of FDDT. CBCT DCG revealed obstruction at the level of common canaliculus, and then we injected the dye, and syringing pressure easily negotiated the blockage at common canaliculus. Dye started flowing through the NLD, showing multiple partial blocks. One more patient with patent syringing, FDTD revealed obstructed pathway on right side. CBCT DCG revealed enlarged sac filled with dye, indicating blockage at the junction of sac and NLD. And then we injected the dye, and even in this case, the syringing pressure negotiated the blockage, and dye went all the way into inferior meatus. Hence, lacrimal syringing is not a reliable test either for screening or for final diagnosis. Back to our first case of congenital fistula, and here CBCT DCG revealed patent pathway, no regurgitation back to the conjunctival cul-de-sac scene. The fistulous tract got highlighted, but there was no exude from fistula. To conclude, lacrimal syringing application needs rethinking. CBCT DCG is best physiological tool to assess lacrimal passage. It can pinpoint the site of obstruction. CBCT DCG has in abundance what lacrimal scintigraphy lacks. CBCT DCG cost ₹1,000 only to the patient. Thank you.
Thank you.
So what dye is used?
Sorry?
Which is dye?
Usual dye Omnipac.
Which one?
Omnipac.
Omnipac.
Yeah.
And but the only problem is this equipment is not readily available at every places. It's a very good technique which you have demonstrated. Cost is also very good.
Yeah.
It's just ₹1,000. But is it available at more centers?
It is
It's a new
available at
technique.
our center because this is a dedicated center for dental radiology. CBCT DCG machine is there adjacent to my premises, and it is available there, and we have been using it for last 8 years.
So is it the routine for you by default mode you would do this for all patients who have lacrimal syringing issues or epiphora?
No, ma'am. No, ma'am. Those patients who are having persistent epiphora in spite of patent syringing, and in those patients in whom fluorescein dye disappearance test is indicating that there is obstruction. In all those cases, we do CBCT DCG.
So there are specific indications for this, and it's not for the...
Yeah.
Yeah, very interesting.
Simple, if there is a regurgitation present on the pressure, there is absolutely no need to do a CBCT DCG.
Okay, thank you,
Any
sir.
side effects of the dye have you seen till now?
Sorry, ma'am?
Side effects of the dye used?
No, no side effects so far. And we have done it in a 3.5-year-old child. And it is the most safest instrument. Ordinary CT scan gives almost 10 times more, what do we call, hazardous
radiation.
Radiation, yes.
Thank you.
Unless and until patient is hypersensitive to the dye, I think there is no other contraindication.
Sorry?
Unless until the patient is hypersensitive to the dye,
absolutely.
Otherwise, there no contraindication.
No contraindication.
Yeah.
Have you published it, sir? Or there are other publications in the literature?
Sorry?
Have you published your data or there are similar other publications?
Yes, I have presented this, not this video, but about this technique in 2021 perhaps, or 19, and my paper was selected as the best paper.
And there are more such publications in literature?
I'm very weak in publication. I'm 68.
No, similar publication with this guy.
I am not in publication business right now. We have published 35 papers. Now I have taken a leave.
Okay, thank you, sir.
Thank you, sir. Thank you. Dr. Smriti Sawani.
That's the last. Anybody else left? Okay.
Good morning, everyone.
In the realm of cataract surgery, surgeons often grapple with unseen challenges that unfold intraoperatively, and the limitations of traditional instruments become evident during complications. In this video, we delve into how retinal tools help in overcoming these challenges through glimpses into real-life cases, offering a first-hand look at how they can be used to address difficult and unusual situations during cataract surgery. Starting with the vitrectomy cutter. In this case of a traumatic cataract, we came across a pre-existing posterior capsular defect intraoperatively. After a thorough anterior vitrectomy, the vitrector itself was used for complete removal of all the remnant cortex. This paved way for a safe implantation of a 3-piece IOL in the sulcus, which was then followed by phacofragmentation for the dropped lens matter. In another case, we came upon a posterior capsular polyp which was strongly adherent at the base and refused to get aspirated through routine methods. It was then carefully shaved off the posterior capsule with the help of the vitrector, making sure its mouth was always kept upwards, thus ensuring an intact posterior capsule. In this case of subluxated intumescent cataract with underlying retinal detachment, creating a continuous rhexis was challenging. The vitrector was used to achieve a circular rhexis, thus avoiding potential complications. It was further used for cataract extraction using the cutter and the suction modes in an alternating fashion, ensuring complete cataract removal. Next, coming to the endoilluminator. In complicated cataract surgery with a hazy view, it's difficult to confirm the integrity of the sulcus. The endoilluminator can easily highlight the sulcus in such cases, and the surgeon can confidently place the IOL without the fear of an IOL drop. In this case of air injection for Descemet's membrane detachment, corneal edema remained unresolved. The endoilluminator revealed that the Descemet's layer was lying scrolled to one side beyond the air bubble, which was then correctly identified and addressed. In this post-traumatic cataract with a severely compromised view, the endoilluminator was used to guide the initiation and completion of capsular rhexis during the cataract surgery. It was also used as a second instrument to assist chopping of the nucleus.
With the assistant holding the endoilluminator near the limbus, the oblique illumination provided was utilized to enhance the visualization of the subsequent steps of the surgery. Thus, the nuclear emulsification as well as IOL implantation could be easily performed. Then coming to the endo scissors. In cases with a smaller than adequate rhexis, the endo scissors can be used to give a precise tangential nick. This can then be grasped using capsular rhexis forceps, and the rhexis can be enlarged to achieve the desired size for phacoemulsification. In this case referred for opaque IOL explantation, the lens was noted to be adherent to the capsular bag by a thick fibrotic band. This was then carefully identified and released with the help of endo scissors, and thus the IOL could be safely removed out of the bag. Next, coming to the endo forceps. During cataract surgery in microphthalmos with a shallow anterior chamber, the fine endo forceps was a valuable tool for grasping the capsular flap and enlarging the capsular rhexis to an adequate size for surgery. In this case of decentered PCIOL, the lens refused to get dialed back in position by the usual methods. The endo forceps was then used to grab the IOL out of the bag in a controlled manner. It was then dialed back in, ensuring a well-centered IOL. When encountered with a posterior capsular rupture, the endo forceps was used for loosening and removal of adherent cortex, thus making it an excellent tool for dry cortex removal. Thus, this video reveals how these retinal instruments are not just tools, but indispensable companions to the skilled hands of cataract surgeons, where they emerge as unsung heroes in the narrative of cataract surgery. The techniques demonstrated can empower surgeons to deliver exceptional care and have profound impact on procedural efficacy and patient outcomes. Thank you.
Do you think cortex removal really can be done by endocapsular forceps?
So there was this one particular case which was shown over here, in which it was very adherent near the capsular margin. So in that particular case, instead of using any other way to aspirate that cortex, we thought it was better to loosen it up first and then use any aspirating method to remove the remnant cortex before going ahead.
I think I'll agree with Dr. Inder Mohan. Besides that, all the places where you showed excellent indication of retinal instruments was good. You should not pull anything once there is a PCR. Even if to loosen the cortex, don't pull anything because you may be causing traction on the vitreous. That is really not recommended. Besides that, every other places you showed excellent use of. So I think what you want to say is we should not only have retinal surgeons as our friends, we should even make their instruments also our friends.
Yes. With the rhexis which you had shown the retractor, I was a little not sure on that account. How would you do a rhexis with the retractor? The anterior rhexis.
Yeah, so in that particular case, it was a subluxated cataract and an intumescent cataract both together. So the vitrector was used in a very high cut rate at around 10,000 cuts per minute, keeping the vacuum to 400 to 400 linear mode. And in that, just keeping the cut rate at very high fashion and keeping the mouth of the vitrectomy towards in a position in which you have a good view, it provided an excellent and very controlled capsular access in that case, because we were worried that doing a capsular access in the usual method would cause some undue stress on the zonules.
Have you tried just the YAG rexes, I mean just a pinpoint for that and then extending it afterwards?
No, no ma'am, sorry, I have not yet tried that, but would love to explore that option.
Yeah. Great, great, Jude.
Thank you.
Thank you so much.
We can
Speakers
please
to come
all the
up
speakers,
for the group
presenters to
picture.
come up for a group photo, please.
Sheet पूरी कर देना.